Hello, thank you for joining me today in the presentation discussing the future of healthcare IT. My name is Frank Fear. I am the Vice President of Ancillary Services and Chief Information Officer at Memorial Healthcare. Memorial Healthcare is a 150-bed acute care hospital located in Owasso, Michigan. We have 26 satellite locations, 170 medical staff. We've been recognized for our use of healthcare IT throughout our healthcare system. One of those recognitions was we were named top 100 most wired health systems. We've been named HIMSS Stage 6. HIMSS rates the overall adoption level of healthcare systems using healthcare IT in a ranking from 0 to 7. Memorial is at Stage 6. And we've achieved Meaningful Use Stage 2, and we'll talk a little bit more about meaningful use and the government initiative program to increase the adoption of healthcare IT across the country. Today I'd like to cover 4 main topics. The first topic is the current state of healthcare IT and focusing on the initiatives facing healthcare systems across the country in the year 2015. Next, I'll talk a little bit about the changes in healthcare, in the insurance offerings, how patients actively engage healthcare, and how IT's role in addressing these new opportunities and in some cases new challenges. The impact of healthcare IT on quality and safety, and then lastly talk about IT's role in maximizing efficiency and productivity. First, let's talk about the current state of healthcare IT. In 2015, a major focus of many healthcare organizations across the country is an initiative called Meaningful Use. That's a government incentive program that was brought forward with the American Recovery and Reinvestment Act to increase the adoption of healthcare IT across the country. And we'll talk more about that in just a moment. ICD-10, which is a new diagnosis, classification, and coding system that will be implemented across the country by October 1 of 2015. And kind of summarize, the overall focus of the country has been on implementing systems and making us electronic, very little optimization, and that will lead us into talking about the future of healthcare IT and optimizing systems to create value for our patients. First, I'd like to talk about meaningful use. Meaningful Use is an initiative that was brought forward by the CMS, Center for Medicare and Medicaid, and was brought forward by President Obama as part of the American Recovery and Reinvestment Act. This initiative was started in 2009, and its main goal was to incentivize physician offices as well as hospitals to implement much more aggressively healthcare IT. In 2009, and there was very little healthcare IT across the country. Stats range from 20% adoption and lower in physician offices, and very few hospitals and physician offices had fully electronic records. The government put together different criterias to achieve your incentive payment. And that criteria was broken down into different stages. The first stage, which has ended for most healthcare organizations, is called Stage 1. Stage 1 criteria for hospitals and physician offices were very much focused on just making areas fully electronic. And there were approximately 20 criteria that needed to be met and to receive your incentive dollars. And I'll go through that in a little more detail here in just a moment. Currently we're in Stage 2. Stage 2 is more focused on continuing the high level adoption of electronic health records, but also starting the exchanging of data between healthcare systems. Stage 3, which will be starting in 2017, is much more focused on engaging patients and having them actively engage and have access to that healthcare record. It also focuses much more on data analytics and leveraging this data to improve outcomes. A great website to learn about the Meaningful Use program is the www.cms.gov/EHR incentive programs. I'm going to jump to that site to show you a little more detail. This is the cms.gov EHR incentive programs website, and it really underlines or outlines the basics of the program. If you can see this link here. And also I talked about the different stages, stage 1, stage 2, and shows the different criteria that need to be met. One of the key criteria that you'll notice in Meaningful Use is submitting clinical quality measures. You can see that's the CQMs. As I talked about in stage 3, the goal will be not only to have physician offices and hospitals be fully electronic, but to start using this data to actively analyze data to determine best practice and to also improve quality through using best practice models. As we look at stage 2 criteria, as I talked about, there were approximately 20 criteria. Criteria changes a little bit as you focus on hospitals, both critical access and acute care hospitals, and physician offices. But I'm going to quickly go through some of the criteria so you can see what hospitals across the country are focusing on to make their healthcare IT systems, make their process fully electronic. The first criteria is computerized provider order entry. With this criteria, and I'm going to quickly go in and show you that, the government focuses on that 60% of medications, 30% of laboratory, and 30% of radiology orders are entered by a provider. Providers defined as a physician assistant, or a nurse practitioner. So trying to get the order entry process fully electronic. I'll be talking a little bit more about that later, but the goal with CPOE is to improve efficiency as well as reduce errors and improve quality and safety of the ordering process. Go through here, recording demographics, making sure that language, sex, race, ethnicity, date of birth, and preliminary cause of death is all documented electronically. Vital signs, height, weight, blood pressure, it's all calculated and plotted. Smoking status, documented for patients 13 years or older. The use of clinical decision support. I'm going to spend a few minutes here. Clinical decision support is essentially leveraging the data within your healthcare information system to drive or recommend different behaviors or actions by a provider. And that could also be a nurse as well, not just a physician, but any person delivering care. And with this criteria that for Meaningful Use, the government has asked that we select 5 of our clinical quality measures and have clinical decision support recommend or drive certain behaviors to improve that quality. Let me go through a quick example. One of those things might be, one of those main clinical quality measures may center around smoking cessation and trying to educate patients on tools to reduce smoking. In a hospital or physician office setting, the nurse documents or asks the patient, or the patient fills out information indicating they're a smoker. A clinical decision support warning would be, as the physician is pulling up their screen to enter orders, the system would automatically notify them that the patient was a smoker, indicated they were a smoker, and the system would automatically recommend, and in some cases pop up a place where the provider could indicate that they need to educate the patient on smoking cessation methods. So it's just one example of clinical decision support, leveraging the data within the system to influence physician behavior. Criteria number 6 to get an incentive is provide patients the ability to view, online, download, and transmit information. This is basically, essentially, a patient portal where patients now are becoming more engaged in their health care. They can have access to their vital signs, medications that order for them, lab results, different reports, discharge summary if they were hospitalized and want to know the summary of care during that setting. This is the start of patient engagement, which is a real focus in Stage 3 meaningful use. Stage 2 starts this. 7 is protect electronic health information. This is a key criteria in that there's been a recent increase in the number of breaches of healthcare information. Healthcare information is in some ways has more value than credit card information. That it contains very much private information about our patients. And this criteria requires that healthcare organizations across the country conduct a healthcare audit and address any deficiencies found. Next is clinical lab tests. Clinical lab tests is when lab work is completed, is done within a laboratory system electronically, and that data is sent to the provider. The focus here is to notify the provider of clinical test results so they can more efficiently respond to those. Generate lists of patients by specific conditions for quality improvement, reduction of disparities in research and outreach. That again is generating lists of patients that may be higher risk and reaching out to them to bring them back into the practice for additional care. Use of the EHR, electronic health record system, to generate patient-specific education resources. This would mean that if a patient came into the hospital or the physician office and the provider indicated certain diagnoses, the system would automatically generate patient instructions to give to the patient to better understand their certain diagnosis, as well as different ways to improve the outcomes of their certain diagnosis. Number 11, medication reconciliation. This is essentially as a patient enters different care areas, maybe the hospital or a physician office, that we accurately capture all the medications that the patient is currently on. This is critical to good quality, safe care, and can be quite challenging as some patients are on many different medications, and it's very challenging to determine what dosage is on, what the medications are, and capturing that. 12, the ability for healthcare EHR system, electronic health record system, to generate a summary of care record and send that summary record to the provider who you are sending the patient to is going to be receiving that care. This is focused on improving care coordination. One of the challenges of healthcare in the paper world is very challenging to exchange data between healthcare organizations. This essentially's goal is to pull data from the healthcare, from the electronic health record, format it in a summary document, and electronically send it to the patient, to the provider receiving that patient, maybe a hospital or a physician office. Capability to send immunization data to a registry. This is where the government is trying to create or develop databases of immunization, a database of immunization or a registry, so the hair care providers can see if a patient needs immunizations or the immunizations are up to date, and if not, recommend different immunizations. And this specifically is around the electronic health records, sending that data to the registry. 14, the 14th criteria is sending electronic lab results to the government, to public health agencies. And this is focused around quality initiatives to improve overall quality in the use of these lab results to analyze different data to improve quality. 15 is electronic syndromic surveillance data. Syndromic surveillance is essentially capturing data for the reason for visit as the patient hits different care areas, may it be the emergency department, the hospital, or physician office. This data is sent to a public health agency, and they analyze this data to determine if there's any outbreaks of any sort of syndrome in our area. So if there's an outbreak of a particular virus, we've had the recent Ebola issue throughout the world, syndromic surveillance would quickly identify reason for visits that would indicate Ebola and then notify different agencies to respond to that much more efficiently. Ability to track medications through a electronic medication administration record. This is where as medications are given, they're documented electronically in the system. What I just represented was the core required functionality for Stage 2 for a hospital organization to receive incentives. Organizations also required to select 3 menu items out of 6 total options. First option is to document the advanced directives. This would be in the case of if a patient were to pass, what would be their directive in dealing with their finances and legal obligations, and who could make decisions around their care as their ability to make those decisions deteriorate. 2 would be electronic notes in the patient record. This is documenting different templates and notes in the system as opposed to using dictation or handwriting documentation. 3 is imaging results. This would be radiology images such as an X-ray, CT, MRI, and having that in electronic health record for easy access, as well as the accompanying report and order. Recording family history as structured data. Electronically prescribing medications. This is instead of prescriptions being handwritten, they're electronically entered to the system and sent to the pharmacy, improving quality, efficiency, and safety. And lastly, providing structured electronic lab results to ambulatory providers. This is as the lab is documented, the lab results are documented in the lab, in the hospital. They're electronically sent to physician offices, fully electronically, to improve efficiency, again, and notify providers of critical or abnormal results, improving quality. So as you can see, these criteria are very broad and in many ways very difficult to achieve. But to this point, 75% of hospitals across the country have achieved meaningful use Stage 2 and received significant incentives. And this has had a big impact on the overall adoption of healthcare IT across the country. Go back to my presentation. So meaningful use, please feel free to visit cms.gov/EHR incentive programs to learn more about meaningful use and its impact on healthcare IT. ICD-10 has been a major project or a major focus for healthcare systems across the country. ICD-10 is due to go live October 1st of 2015 in the United States. ICD-10 is basically a new system to translate diagnoses into unique codes. These unique codes are used for reimbursement and payment, statistics, as well as clinical decision support. And I talked a little bit about clinical decision support with meaningful use. It's identifying diagnoses and then recommending to a provider different orders, patient education, and just different recommended plans of care to that clinician. The U.S. is one of the last developed countries to implement ICD-10. ICD-10 has been around for over a decade, and we're currently using ICD-9. The challenge with ICD-9 in diagnosing as a coding methodology is its limited availability to provide specificity. It's a coding system that has a maximum of 14,000 codes. With ICD-10, will increase to 68,000 codes, which allows for new diagnoses that have been developed and then much more specificity for those diagnoses. ICD-10 really requires a lot from the electronic health record system to make it functional. It supports the EHR must support all these new codes, but more importantly though, it's about impacting workflow. As providers now will need upgraded systems to more effectively and efficiently select the right diagnosis code, as well as different billing and clearinghouse systems will need to be upgraded and workflows enhanced to take those ICD-10 codes to ensure that organizations are paid appropriately, and as well as the clinical decision support can function properly. We'll support enhanced documentation. The EHR will need to support enhanced documentation to support these more specific codes. When a provider selects an ICD-10 code for a more specific diagnosis, the documentation must also spell out or explain the reason for that code. New templates will need to be developed and designed that are efficient in use to be able to outline the need for a specific code. So ICD-10 is a major initiative in the United States in 2015. But there are major changes in healthcare that are coming or have already come. And I want to go through some of those with the group. In this section, I'll talk about the major shift from hospital-based work and hospital setting to focus on outpatient. So much more volume is moving from the hospital setting to physician offices, ambulatory surgery centers, and just outpatient focus. Talk about the Accountable Care Act and new insurance models, how that's impacting healthcare and IT's role. The shift from volume and fee-for-service to more of a value focus, where we're going to be getting more and more incentivized, healthcare systems will be more incentivized on improving quality and getting paid based on quality, and less on the volume that we see or that fee-for-service. Population health and new insurance models that look at an entire population and identify higher risk patients and trying to manage their care. A significant amount of the cost of healthcare is focused on patients that are high risk. They have 3 or more chronic diseases, and in population health, using data analytics to identify those patients and manage or help manage their care more effectively to reduce costs and improve quality. Telehealth and telemedicine and new ways to care for patients, really focusing more on patients as customers and delivering value to a patient, and just overall data analytics. First, let's talk about the Accountable Care Act. The Accountable Care Act was really driven or focused on reducing the cost of care, health care in the U.S. We've seen escalating costs as the U.S. is one of the most expensive healthcare systems in the world, although unfortunately our quality has not improved in proportion or ratio to that increase in cost. Our increase in cost is not sustainable. The government developed the Accountable Care Act to try and improve the overall quality of care across the organization. And the focus really is on quality outcomes. I talked quickly about a little bit about how currently healthcare and how we're reimbursed is primarily focused on volume. For example, the more CTs or more MRIs an organization does, the more that organization is reimbursed, thus improving their financials. This new shift is more on quality outcomes. One of those programs that are centered on Accountable Care Act is the Value-Based Purchasing Program. The Value-Based Purchasing Program centers on 3 key criteria that will determine the amount of reimbursement that an organization will receive for their Medicare patients. And the first criteria, again, that's focused on outcomes, is the HCAHPS, or patient satisfaction scores, how satisfied a customer is. So this centers on criteria such as likelihood to recommend, quietness, cleanliness, care provided by the nurse, explanation of different medications and discharge instructions. Every patient who's seen in a hospital across the country is sent a HCAP survey. Patients respond to that survey, and based on the responses, reimbursement is impacted. The second aspect of value-based purchasing is outcomes. And this is focused on readmission rates, mortality rates. So this is how effectively does the organization improve quality, how effectively is the care they provide in preventing a patient from coming back to the hospital. That is defined as the readmission rate. The lesser often a patient is readmitted after a period of time, the higher reimbursement organization will receive. Inefficiency. The efficiency that a healthcare organization provides, basically lowering the cost of healthcare, also impacts the amount of reimbursement that a healthcare organization will receive from the Medicare patients. And again, these criteria, much more detail, but this is the value-based purchasing program that the Accountable Care Act has that is designed, that focuses on quality outcomes being associated with the reimbursement the organization will receive. The Accountable Care Act also introduces the concept of accountable care organizations. An accountable care organization is basically a grouping of doctors, hospitals, and other healthcare providers to coordinate care. And this has a couple of different aspects to it. Where a patient who's a member of an accountable care organization, that essentially becomes their insurance carrier or where they seek care. As they enter the healthcare system, let's say they enter an emergency department, they receive that care in the emergency department, and as if they need to be transferred to a higher level of care, a healthcare organization is defined within that accountable care organization to provide that higher level of care. So if they need to be transferred to an organization, let's say for a heart cath, and that emergency department does not provide that service, that emergency department's partnered with another organization to do that much more efficiently and much more cost effectively. That patient's transition to that new healthcare organization, that cath is completed, and then if that patient needs home care, that home care is also has partnered with the accountable care organization, where they've developed different methodologies to provide a more streamlined, efficient process with more coordinated care to improve quality and reduce cost. One check, one payment is then sent to the accountable care organization, and those funds are then distributed between those different care areas that provided care for that patient. So that might be the emergency department, could be, as we talked about, it would be the organization providing that cath, as well as the home care agency. Again, the organizations partnering together to provide more efficient, coordinated care that's higher quality and reduced costs is the goal of accountable care organizations. There's been pilots across the country with accountable care organizations, and there's been very mixed results with the impact on quality and efficiency. So more to come with accountable care organizations. Also with accountable care organizations, starts to introduce the idea of population health. Population health is the concept where patients pay a per member or per month cost for their health care. And healthcare organizations receive a flat amount for that per member per month fee. The goal of the healthcare organization then is to identify patients and that are higher risk, to improve their care to lower cost, as well as improve the quality and efficiency of care across the population, in that that healthcare organization is receiving a flat dollar amount to provide care for that population. This is also being piloted across the country to determine the impact that a healthcare organization managing a population of patients would have on quality and efficiency. As we look at healthcare IT's role in accountable care organizations, as well as focusing on outcomes, there's significant need for healthcare IT to be leveraged to enable accountable care organizations in population health. In population health, I'll start with population health. Different data analytic tools will be used to analyze the entire population, determine patients that are higher risk. They would identify patients with 2, 3, 4, or more chronic diseases, and that will be used to help reach out to those patients, engage those patients to improve their care. It'd be very challenging to do this type of analytics without healthcare IT systems. When we look at accountable care organizations where different doctors, hospitals, and different healthcare providers are partnered together to improve quality, transitioning of data, healthcare data, as the patient goes from one care setting to another will need the use of healthcare IT to make that possible. Such things as medications, laboratory results, tests done will be transitioned between these different healthcare organizations to improve quality so that better coordinated care, but also improve efficiency of care, reduce costs, so that duplicate tests are not done. The CT was done in the emergency department, and that data then is sent to the higher level of care needed for a patient. To prevent that CT from being done again, that report and images will be sent to the higher acuity of care provider. As we look at telehealth, is another opportunity for the use of tools and technologies to improve the overall quality and efficiency. I'll talk a little bit more about telehealth in just one moment. So a major shift, though, from the patient being more viewed as a consumer or a customer of healthcare. Up to this point, research shows that insurance and physicians really play a major driver for care decisions. As you look at yourself as a patient and you're seeking care by your family doctor, if you're in need of a surgery, today you would likely look to your primary care physician's recommendation of where to go. That makes a major influence on where you would have that surgery. Also, your insurance plays a major role in that which providers, which hospitals, which surgeons are going to pay for that procedure. So as you look at your own healthcare experience, you can see where insurance and your physician play a major role in the referral patterns and where you receive care. But there's a major shift happening where patients are playing a much more active role in driving care decisions. Where patients are more consumers of healthcare. That's being driven by higher deductibles and just overall tools that patients can now use to identify and look for potential areas or healthcare systems that provide higher quality, and they're looking for cost. There's price shopping to see if there's different ways to reduce that cost, or look for a lower cost option. For example, if you get a CT, you get a recommendation that you need a CT or an MRI, you have now the ability to price shop and see if there's a less expensive option for that CT or MRI. Healthcare IT plays a major role in engaging patients in this new paradigm shift where patients are viewed more as customers and really driving decisions on where they receive care. The first is patient portals, and I talked a little bit about that in the meaningful use criteria. With patient portals, patients can go online and look at their healthcare information. They can look up such things as lab results, medications, vitals, allergies, radiology reports, images. It's a tool that enables the patient to be really more engaged in their care and make better healthcare decisions as they're more aware of their care and what's going on with their care. More new tools are being developed to engage patients. These tools are centered primarily around mobility and mobile apps, where patients can install applications on their mobile phone and can be notified of new lab results that come in. They can be notified of when to take their medication. These can be major differentiators for healthcare systems to drive patients to their organization to receive care, and can be viewed as a satisfier to improve customer service. We're seeing a major shift where healthcare organizations are now trying to create more of a hospitality environment and less of a clinical environment. Examples of that are private rooms. We're seeing where there's rooms where there's only one occupant instead of two. But some of those tools that we're seeing in healthcare IT that are being leveraged are patients have the ability now to have access to wireless technologies while they're in the healthcare system, connecting to the wireless, accessing their patient portal while they're being cared for, as well as patient entertainment systems, where as you go to a hotel, you can quickly and easily download movies, play games. Now we're seeing that in healthcare, there's a shift for this hospitality environment where IT can be used to create much more of a hotel-like experience where customer service and trying to create more soothing and comforting environment is a major focus to try and drive patients and be a competitive advantage. Telehealth or telemedicine has been another key focus to try and drive down the cost of care while addressing, customer demand or customer desire. Patients have said that indicated that they would like to have e-visits. That's one type of telehealth service. E-visits are where you could have a virtual physician office visit. Let's say, for example, you're working in the yard and you've stepped in some poison ivy and you're starting to itch and you need care. You'd be able to go online, connect with your physician electronically, virtually, through a video conference, document the different medications you're on, you potentially even take vitals, send that to the provider, and the provider could then send you a prescription for a medication that would help you with that poison ivy. Again, lowering costs while delivering a higher quality of service to the patient. Other types of telehealth service are specialty consults. So the patient, give an example, patient comes to their emergency room with potential stroke. With different tools and technologies, with telepresence, video conferencing, we could then connect in a specialist, a neurologist, that could quickly, rapidly diagnose the patient and recommend different medications for that stroke or different therapies for that stroke, improving the care as well as improving overall quality and efficiency. Psychiatry is another example, and oncology is another example, where a patient is in the hospital or being seen by their physician office, but they'll connect in a specialist who's focused on a particular type of cancer, and they can provide services remotely. Virtual hospital rounds is another tool that could be utilized. Home visits for home care is another opportunity that's being explored, where you put monitors in the home that would recommend or remind the patient to take their medications. They would take vitals, and if there were any dips or major changes in vitals, let's say a patient's had a significant weight gain or their blood pressure changes significantly, provider would be notified electronically, and that provider, then home care provider, could respond to that much more efficiently than the traditional home visit where the home care provider comes into the home to provide care. Telehealth is more of an exploratory tool in the home visits and the e-visits realm. We're seeing quite a bit of an adoption in specialty consults with neurology, psychiatry, and oncology. Primarily that's due to there's a reimbursement model for that specialty consult care. Insurance companies are still piloting payment models for home visits and e-visits. But as we look at better, more coordinated care with the Accountable Care Act and accountable care organizations and the whole concept of population health, telehealth can play a major role in improving that care and really enabling those different models of payer models or insurance models. Healthcare IT plays a major role or a major focus in improving safety and quality. Today I'd like to go through some of the National Patient Safety Goals, the 2015 National Patient Safety Goals, and identify how healthcare IT impacts those. And then I'll focus specifically on computerized provider order entry, or the use of the computer to enter orders, and to bedside medication verification to improve the quality and safety of the administration of medications in a hospital setting. National Patient Safety Goals are key goals that different accreditation organizations provide to hospitals and health systems and urge the focus or require a focused quality initiative to improve performance on those particular goals. Talked about accreditation organizations. Every hospital across the country who receives Medicare reimbursement is required to be accredited. There are various different accreditation bodies. Memorial Healthcare has selected the Joint Commission to be our accreditation body. Every few years, Joint Commission comes in and surveys our organization to ensure we're providing the highest quality of care and meeting different regulatory requirements. In 2015, you can see these are our National Patient Safety Goals. Again, the Joint Commission requires that we focus on these initiatives and come up with different initiatives to improve the quality of care provided, centering on these goals. The first patient safety goal is identify patients correctly. I'm going to switch over to actually showing you the 2015 Hospital National Patient Safety Goals. And again, I'm going to focus on where healthcare IT can impact performance on those National Patient Safety Goals. So the first one, as I said, is identify patients correctly. Use at least two ways to identify patients, for example, patient's name and date of birth. One of the major ways that healthcare IT impacts and can improve patients correctly is that patients, when they become admitted to a healthcare organization, have a wristband with a barcode on that. That wristband can be scanned to identify and determine that you have the correct patient when you're administering medications, drawing blood as a phlebotomist for lab results, and many other things. There's also new palm scanning technologies have been used to identify patients at registration, so that to reduce identity theft, and also just to improve the efficiency of to identify the patient. You also notice that it says make sure that the correct patient gets the correct blood during a blood transfusion. Electronic health record systems have tools called blood bank modules that basically identify the patient and their blood type, and before the blood is transfused, we scan the patient's armband, scan the blood to ensure we're giving the right blood to the right patient. Improve staff communications, the second National Patient Safety Goal. Get important test results to the right person on time. As test results are complete in electronic health record, the electronic health record system looks at those lab tests and determines if any of them are at a critical range or abnormal range. and certain clinicians are notified of those results, those critical results. And based on the criticality of the result, different notification methodologies can be implemented. At Memorial, when a critical result is completed, say it's a radiology report, and it's determined that it's a critical result from that radiology report, a pager goes off notifying staff in the radiology department that that patient has a critical result, and the provider is called to notify them of that result. As well as the provider in the electronic health record, when they receive that result electronically, it indicates that a critical result, also notifying them to follow up on that result or report. Next patient safety metric is, or initiative, goal for 2015, is use medications safely. This centers on labeling drugs correctly, record and pass along correct information about a patient's medications. That's the med reconciliation piece. Documenting the correct home meds. And the electronic health record plays a major role in improving the use of medications safely. Next is use alarms safely. This is make improvements to ensure alarms on medical equipment are heard and responded on time. Some examples of how healthcare IT impact the use of alarms safely is that certain alarms, for example, a telemetry system showing heart rate can send an alarm right to a nurse's or physician's mobile phone, alarming them of out-of-range data. As well as there's a concept of alert fatigue, where as alarms go off through a healthcare organization, different noises, buzzing, lights going off, sometimes with alert fatigue, it's difficult to differentiate between the urgency of those types of alarms. With healthcare IT systems, it can leverage those alarms, look at those alarms electronically, prioritize them, and also send them to the right care provider to respond to them, making it much easier for a care provider to differentiate the alarms that need to be more urgently dealt with as opposed to ones that are important but can be responded to in different ways and different mechanisms, such as the use of different staff or personnel to address that alarm. Next, prevent infection. Using proven guidelines to prevent infections, you can also notice it talks about blood from central lines, infections from surgeries, and so on and so forth. Healthcare IT can be used in many different ways to prevent infections. One is in the ordering process, in that orders can be defaulted, requiring antibiotics be administered to prevent infection after surgery. As well as different timeout forms can also be utilized to ensure that certain things are done before, during, and after surgery to improve overall reduction in infections. Urinary tract infection, nurses can be notified, providers can be automatically notified to remove the catheter to reduce infection. Next, identify patient safety risks. So you can see this is focused on reducing or preventing suicide. Different forms can be built and created in the electronic health record. They can profile or identify patients that are potential suicide risks and notify staff of different precautionary measures. Prevent mistakes in surgery. And this is mark the correct placement of the patient's body for the surgery to be done, correct surgery done on the correct patient. We've talked a little bit about patient identification and different tools that can be used to ensure that we're performing the correct surgery on the correct patient. So the National Patient Safety Goals, you can see in 2015, many, if not all of them, can be impacted by healthcare IT. Computerized provider order entry is a key tool that's being implemented throughout the country to improve quality, efficiency, and safety. The first thing it addresses is just simply handwriting errors. It can be challenging sometimes to read a person's handwriting. Then secondly, there's many look-alike, sound-alike medications that it's sometimes challenging when handwritten with spelling errors to determine which medication that the provider desires. With CPUE, it overcomes that by making prescriptions electronic as they go to a pharmacy for being filled, as well as when they're being administered in a hospital, to ensure that they're very legible and easy to read. With CPUE, you can also develop evidence-based order sets that are focused on particular diagnoses, that are designed around best practice. So for example, a patient is in the hospital with pneumonia. An order set can be developed or designed that has the best evidence, the latest evidence on which antibiotic should be administered for that type of patient. In this case, it's pneumonia, to improve outcomes. And then lastly, improve efficiency. Time studies have been done showing that medications are much quicker administered by the use of CPUE. I'll just give you a quick scenario of a paper-based process and how CPUE can improve the efficiency of that process. With a paper-based process, the physician writes on a piece of paper the order for a particular medication. That medication then is given to the nurse. The nurse takes that order, verifies that order on paper. Then they give that order, that piece of paper, to the pharmacist to also verify that the medication is correct. Once the pharmacist verifies that order, that paper order then will go back to the nurse to administer the medication. There's many steps in the process with a handwritten order in that taking that information on paper and transitioning to different care providers, maybe from the doctor to the nurse into the pharmacist, takes time and are barriers in the care process. With CPUE, the minute the order goes into the system, it can notify the provider of any sort of allergy to that medication and tell the provider that they need to change that medication order to prevent allergic reaction. But then if that order is correct, it immediately goes to the nurse to verify. The nurse verifies that order, goes to pharmacy immediately, pharmacy reviews that order, and comes back to the nurse immediately for administration, cutting down many steps in improving the process. Bedside medication verification has also been a huge improvement in quality throughout the country. Bedside medication verification is simply the process of, before a medication is given, the nurse scans the patient's armband, scans the medication, and it makes sure that we're achieving the 5 rights. Those 5 rights are that I've given the medication to the right patient, the right drug is being given, that it's at the right dose, it's at the right route, meaning orally or through IV, and then lastly, that it's being given at the right time. Bedside medication verification was a tool that was developed based on a study that came in 1999 to Error is Human, where they found that 44,000 to 98,000 people per year were dying due to medical errors, and medication errors is found as a major contributor to death within healthcare systems. BMV's implementations have made a major impact on improving quality and reducing mortality. Big data, as it's called, is using data analytics to improve quality. What we're finding is more and more tools that do real-time patient monitoring. And one of those tools to improve quality in real time is identifying and responding to sepsis. Sepsis is a major contributor to mortality in healthcare organizations and has been a major focus across the country. So an example of real-time patient monitoring, as the patient is seen in a healthcare setting, maybe a hospital, emergency department, different data is being entered into the system. Vital signs such as heart rate, temperature, blood pressure, different labs are being done. Those different points of information can start to detect if the patient is susceptible to sepsis. and the nurse can be notified. Nurse can then do additional testing to determine if this patient has potential sepsis. As that patient potentially escalates or progresses in having sepsis, the physician can then be notified, and the physician then can take action, either ordering medication or ordering different tests to determine if the patient has sepsis. Secondly, data analytics can look at data, determine best practice. And this is quite broad, but can be utilized, for example, for oncology treatment or different chemotherapy treatments and their efficacy or impact on cancer care. Looking at large populations of patients with different types of cancer, looking at chemo and different results, different regimens of that chemo, and determining best ways for that particular cancer and which medications to order to improve outcomes for that type of cancer. Just one example of looking at data and determining best practice for a particular diagnosis. And genomics has become very big in that, looking at gene sequencing to determine potential diseases that a patient might have, and really doing more preventative care to, as you would know or learn about a potential disease and the likelihood a patient would have that disease based on their genetic makeup. And we're seeing more and more of that as tools and technology can do the gene sequencing much more rapidly. And we're learning and profiling those different gene sequencing, determining different disease or chronic disease states. Healthcare IT also has a huge impact on improving efficiency. Through improving coordinated care as data is shared between different healthcare providers, reducing duplicate tests, using healthcare information exchanges to exchange data across the country and across different healthcare systems. A particular tool that's used is called direct messaging, is used to exchange data between healthcare organizations. And then lastly, kind of the lean process, and using lean as a tool to reduce waste out of the healthcare system. Health information exchange. Health information exchanges are used to improve the coordination of care. Health information exchanges is kind of a broad word, a broad idea, but it's basically being leveraged by different state and national organizations where there's different data repositories of healthcare information, and as the patient is seen for care, the healthcare provider, maybe a physician or healthcare or hospital, can query that database for different information such as medications, different tests that the patient's had, may it be a lab result or CT. It can be used to reduce duplicate testing to improve quality and efficiency. And direct messaging is a key tool that's used as a patient seen in an area to communicate data to this health information exchange repository of information. Lean process improvement is also a key tool or methodology to improve the efficiency of healthcare. It's a process to identify and eliminate waste. And waste defined in healthcare is non-value added activities to the care process. It's a process where you engage the staff, provide care to look at different tools and technologies to improve efficiency, to leverage tools such as bedside medication verification, CPUE, which we've already discussed. In summary today, in today's presentation, we looked at how IT plays a critical role in addressing different healthcare challenges, where we've moved from implementing systems to trying to create value through the use of those systems, and value being really focused on improving patient outcomes while reducing cost. Thank you for attending today's presentation. Please feel free to contact me on my phone number, or emailing me. As you can see, my phone number and email are displayed. Thank you and have a great day.